We're taking this, 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 we're taking with a pinch of salt.
Dear colleagues, welcome to A Pinch of Salt, the nephrology podcast that tries to answer the simple yet very relevant questions arising from regular clinical practice. Today we're focusing on polycystic kidney disease, so you can expect to hear about what's the difference between polycystic and multicystic kidney disease, how to best diagnose PKD, when should we do genetic tests and what we can get out of them, who needs to get their brain arteries checked, how much water you need to drink, and some other clinically relevant issues as well. With us today is Professor Roman Ulrich-Müller from Cologne. Roman is an expert in PKD and genetics and is currently the chair of the Genes and Kidney Working Group. Roman, welcome to A Pinch of Salt.
Thank you very much, Andre, for having me here today. It's a pleasure to be here.
Thank you for joining us. It's our privilege. So maybe we start off with a very simple question, but which sometimes may cause some confusion. So there's polycystic kidney disease, and then there's multicystic kidney disease. So a lot of cysts in a kidney, but not polycystic kidney disease. So this is not the same thing, right?
Right. And then the question is also what people understand when you tell them these terms, right? And that'll be interpreted in a slightly different manner. But polycystic kidney disease, I would define it from two sides, right? On the one hand, if you talk about polycystic, you really mean those disorders that come with a lot of cysts and usually all over both kidneys as rather classical monogenic inherited disorders that come with the disposition to form cysts of pretty much all cells affected in the kidney, all tubular epithelial cells, right? With the most common disorder being autosomal dominant polycystic kidney disease resulting in positive family histories, 50% risk of inheritance, etc., pp. Now, there is also cystic kidney disease. There is multicystic kidney disease. There's many diseases that go along with cysts. And for example, nephronophthisis is among those. That's rather on the side of having few cysts at a very defined pattern at the corticomedullary border, but usually much less cysts. And that's why I would not talk about polycystic in this case. And then there is multicystic disorders, and there's a couple of different ones that, this term is often used in a different setting. Most commonly, it's used for the developmental dysplasia of kidneys in children, that a whole kidney and is, for example, and that's often unilateral, replaced very early in development and it results in dysplasia that comes with cysts, usually in number much less than in classical polycystic kidney disease as a progressive disorder over life, and rather falls into this whole field of congenital anomalies of kidney and urinary tract, so the Kakut area of kidney disease, and that is much less of a clearly defined monogenic disease, right? There are families affected by that, but in each individual may look different, and there can be reflux can very often be a manifestation, and one family member may have those multicystic dysplastic kidneys while another one only has reflux. But the majority of cases are actually sporadic, and that's one of the other key differences. And the third thing where people sometimes use this term is actually the what happens to kidneys after reaching kidney failure, right after dialysis. So these kidneys get fibrotic, they get multicystic as well, start forming cysts. And this is a bit of a setting in which we assume we also have an increased risk of renal cancer formation down the road. So these papillary tumors that form specifically in this setting where follow-up imaging, which we often forget when people don't have kidney function anymore, right? We might need that imaging. And that's one of these multicystic settings, and also a setting in which this term is used. But again, this is not a genetically defined disorder, but a consequence of having lost kidney function and having non-functional kidneys in your body.
Exactly. Thank you for clearing that up. So today we're going to talk about the classic autosomal dominant polycystic kidney disease, and how do we diagnose that? Kidney ultrasound, at what age do we start? When they're children, adults, young adults, or just go straight to genetic testing?
Yeah, I mean that it is in itself an area of controversy even in the field, right? So I'll give you my impression and I'll give you reasons for that, and people can make up their mind to a certain degree. And in many cases, it is, as always, you have to talk to your patients and the families, right, and the parents to make an informed decision together when testing makes sense. Let's start with how do we test? In principle, there are good imaging criteria to make a diagnosis in patients, or exclude the diagnosis as well, right, in patients with a positive family history. So if you have a normal pattern of autosomal dominant inheritance, and that's quite clear, you can use ultrasound and or MRI to either diagnose or exclude the diagnosis. And we know nowadays that even early on, and those were classically the ultrasound Ravine criteria, and your Pei extended that with his work later on. And we know that if you look at an MRI, even early in life, at the age of 16 years, right, you already have loads of cysts. So somebody with a single cyst can actually be exclusion of the diagnosis. So you would expect something like 20 cysts in those affected, and then it's a little bit age dependent, obviously, what you'd find. This is sufficient in the vast majority to either make a diagnosis or exclude a diagnosis, and it's certainly sufficient at an age a little bit older, above the age of 30 years, right? Now, do we need genetic diagnostics? Well, on the one hand, these criteria are not that, are not well established statistics-wise, I would say, for patients without a positive family history. That's number one. Number two is there is added value to having the genetic information, and that comes with the fact that we nowadays have to assume, in genetic disease, while the phenotype on the kidney side with a lot of cysts can be similar, there may be extrarenal manifestations that differ depending on genotype, or the disease course is highly different. And we already know, when we look at the two most common genes, which are PKD1 and PKD2, that the mutation type guides us in assessing how severe the disease will be later on. And now with the expanding list of genes, we now know that at least something like 10 different genes are involved in this disease, right? Every single one will have a slightly different disease course later on. So it's surely added information, even if not required to make a diagnosis in families with a positive family history. And that takes us down to the second question: when do we test? That's a difficult one, in the sense that, we're quite sure nowadays that if somebody reaches 18 years of age, we have a treatment option with tolvaptan. So then we need to know, right? That's when we need to test in whatever way to make an indication for this treatment. The one thing that speaks against that, and that's very much country specific, is the fact that sometimes getting insurances is a problem, right? Even if you're an adult and you don't have all insurances yet, or if you want to come into certain positions as a government official in Germany, then you might have a problem with the diagnosis, and that has to be taken into account and has to be discussed with pondering the advantages and disadvantages with the young patients. But usually, medically spoken, the idea would be clear to get testing there. Now, when it's about children, then this insurance question would also play a role. However, there's other arguments that speak against testing. You might not, if you don't have any consequence of the testing, you might not want to move ahead in a young child or adolescent and put a diagnosis on this person.
Yeah.
What has a consequence in children? And that is a very individualized decision that can be discussed with adolescents, can be discussed with parents before. We do not, at least not test at a routine setting, but we discuss this with our patients together with the pediatricians. What's the thing that has a clear consequence on the therapeutic level as well is hypertension. And we know that at least a third of children with ADPKD do suffer from arterial hypertension that would need to be treated. So the least we recommend is, if there is no testing, which is well warranted, we don't necessarily have to test, But we do measure blood pressure in a 24-hour ambulatory blood pressure monitoring setting to at least be able to make the point, is there arterial hypertension, and we start antihypertensives or not, because that would be a disadvantage of these children if they reach the age of 18 with 12 years of arterial hypertension before.
Yes, brilliant. Very well explained. Thank you. So you've mentioned already PKD1, PKD2, the most common mutations associated with polycystic kidney disease. So if we don't find one of these, which can be very revealing about in terms of prognosis, as you said, how hard should our geneticists look for other? You mentioned 10 genes that are involved. How hard should one dig if you don't find anything in PKD1 or PKD2?
I mean, this always depends on resources in medicine in a way as well, but the landscape is greatly changing, right? When I started medicine, we kind of tried to avoid testing because it was hardly accessible, and was expensive, and that's not the case anymore in most settings. And then this is again partly country specific, but in most settings we're now moving towards not doing Sanger sequencing for individual genes. For PKD1, for technical reasons that might lead too far today, this may still be the thing we have to do. But for most other genes, the idea is we rather get exomes nowadays, right? Not even physical panels, so not even deciding we do those 20 genes, but we sequence the full exome. The future may even be genome. So we have all the information. We never look at all the information. And the reason is we're just going to find incidental findings which we can't interpret. So we still look at the data in a disease-oriented fashion. And if we tell the geneticists, right, this is polycystic kidney disease, they'll look at a panel of, 10 to 20 genes associated with this specific disease and then give you the feedback. So we're not that limited anymore. And in this setting, yes, I would definitely recommend that geneticists and nephrologists together always look at all the known genes, because that's the way we learn in the future what happens to patients with a specific genotype. And it may also guide therapeutic decisions. We're in the process of learning that some extrarenal manifestations like aneurysms may differ in frequency. We do know that most of the non-typical mutations or genes affected come with a slower disease course, and all of these things are important for therapeutic decision making. So yes, knowing the genotype will get more important. I'm quite convinced, not being published yet, this will also be emphasized by the upcoming KDIGO guideline, that this is something we should know and should always provide as an information there, if accessible in the setting we work in.
We recorded one podcast with our colleague Emilie Cornec-Legol, and she made a good analogy between the relationship between the geneticist and the nephrologist could be or should be similar than between the pathologist and the nephrologist. So to get the real results, you need the collaboration of the two, the collaboration of phenotype and what you see on pathology, or in this case, genetics. So I guess these discussions, should we do genetics or not, will sound like should we do biopsies or not in 10, 20 years' time, right?
Yeah, no, absolutely. And we need to talk to our geneticists, right? You can't just send them the patient as a black box and say, test, I want to know what this patient has, but the information is needed. We need this discussion, and that sometimes then needs expert centers as well that know how to have these discussions, have nephogenetics boards and so on, not for the simple patient in whom, we have a clear phenotype, family history, and then a simple PKD1 mutation. This is probably resolved on its own. But for those that are more complex, this interaction is extremely important. And another thing that comes with the fact that we have a lot of data and may not always find the mutation which is responsible for the disease is that we should tell our patients, and should be aware as nephrologists as well, that it is wise to revisit that data 5 years later, right, on a regular term, in a way that is governed by reimbursement schemes in different countries again, and so on. But in general, that principle of saying, okay, we didn't find anything, we have the data 5 years later, we may know more about the disease, we look back and find that the gene that was newly identified is affected, is really important, because having done genetics once doesn't mean we've done everything that's possible. This will change so rapidly over a few years.
Sure. So how often does it happen in your case, or like an expert center, how often does it happen in your case that you do not find a mutation? What's like the percentage where you do not find a mutation, even though the phenotype is obviously something close to polycystic, autosomal dominant polycystic kidney disease?
Yeah, I mean, this is nowadays still around 10%, right? That we don't find anything. And it's even more common in an expert center often because you get those
Yeah,
atypical cases.
sure,
So
sure.
it's even enriched, but you have to expect that if you send a patient for sequencing from a family, either, a sporadic single patient or from a family with a positive family history for which there is no mutation known, that there is a relevant risk of not finding anything. And
Mm,
that does not exclude polycystic kidney disease. That's another misunderstanding, right? If you sometimes people send patients for sequencing genetic diagnostics and then there is no mutation and they say ADPKD was excluded.
yeah,
Not true.
yeah.
In this case, it's still the clinical diagnosis that governs the full thing, but we didn't find the cause yet, and we'll have to revisit the data we have, like, 5 years later, and we might find it.
So how about brain aneurysms? I think we're all scared of these, and anytime the patient has a phenotype of autosomal dominant polycystic kidney disease, you're afraid of a aneurysm rupture. Who needs a cerebrovascular angiography? Is it everybody? Only people who have had sudden deaths in their family? What's the current opinion on that?
Yeah, so most expert centers you'll ask, and there'll be exceptions from the rule as always, but and you'll find the consensus in the upcoming KDIGO guideline then as well would not recommend routine testing for everybody. And that has a couple of reasons that's behind that. If we do routine testing for everybody, this would mean we don't only have to do it once, we'd have to do it several times to be really sure, because obviously these aneurysms can develop over lifetime, so we'd end up with loads of MRIs, incidental findings, and so on. That's already something. Nowadays we do volumetry for everybody and we have a lot of incidental findings we also have to work with, but the volumetry has a consequence. The other thing for the intracranial aneurysms is if you find something, the question is, what do you do, right? And this is not necessarily simple. And living with finding something, you give the recommendation not to do anything and just live with it is sometimes even more difficult than finding something. And it's quite clear that the interventions themselves come at considerable risks of disabilities. So in general, those are two key reasons why we feel that not everybody needs screening at the moment. But we do identify high risk settings from several angles, right? One reason to look at a high risk setting is you have a patient that on top of having ADPKD has a second key risk factor, and that in this case is positive family history. That increases the risk so high that testing makes sense, especially if there's family history for intracranial hemorrhage. Then these we know that's like in the common population, people that have this positive family history that will then have a considerably higher risk, and those should undergo MRI without contrast agent MRI, time of flight angiography. That's a simple thing to do. There's a couple of other settings we use in that sense that could be high risk professions, right? Being a pilot. So 200 other people depending on your outcome, and that's an unexpected thing they normally don't get tested to. So it's a higher risk population you would go for testing. Another thing is symptoms. So acute headache and so on, you have to think of this. And the last thing we use this for is obviously if the patient wants to go for testing, right? So you talk about it, and if in the end it turns out risk and benefit, the patient feels, I'm afraid, I want to know, that changes things for me. Anxiety is associated with not knowing, then we do also test. There's always been a discussion what happens before surgery. We don't do that at a routine setting, also because the risk of a rupturing aneurysm in a surgery is mainly linked to the blood pressure changes during surgery, but those also occur in everyday life. We do sports and lift weights and so on, then we would find thousands of reasons. One setting we usually discuss this with our patients is transplantation, and especially in living donation. And the reason for living donation is that in contrast to people on the waiting list for deceased organ donation, is that we know the exact day when the surgery will occur. So we can tell right then there is nothing there. And then also also psychologically, in a sense, the fate of the donor kind of depends on the outcome. So we feel that in this setting, there is an added benefit of MRI angiography before transplantation as well. But that's not necessarily consensus. While symptoms is obviously consensus, and high-risk settings with positive family histories too.
Interesting, interesting. So we all know about tolvaptan, I guess, but what about people who are not candidates for tolvaptan yet, perhaps? What information do you give them in terms of how much fluids they should drink or any specific diets? How do you approach patients who will not be receiving tolvaptan in the near future?
Yeah, that's a good question. Obviously, that also tells us that we're really lacking therapeutic opportunity still, right? Because we don't have anything targeted there. Patients that are not on tolvaptan, and most of those things also apply to tolvaptan patients apart from the fluid intake. But when you think about fluid intake, there is always the pathophysiological consideration that increasing fluid intake over the limit, that it suppresses urine osmolality below 300 or 270 milliosmol per liter, will then suppress vasopressin excretion, and by that could slow disease progression. And that is a very wise pathophysiological consideration, also knowing that tolvaptan blocks vasopressin action. However, there is no good data showing this, and the only trial that was ever done by our colleagues in Australia, Prevent ADPKD, did not show any benefit of prescribed water intake. There is some things that are still uncertain. The difference between the intervention and non-intervention, the control arm, was comparatively small in this trial. But so far, we have to say we have no data from a clinical trial showing that increased fluid intake really helps with disease progression. We still tell our patients, for this pathophysiological consideration, they should drink enough. And then there's a second reason, and that's kidney stones. There's a higher risk of kidney stones in those patients, and then fluid intake may help. And we usually tell them, yes, you can see that you drink enough water, and you can go up 3 liters and above could be a goal, but not much more either, because without tolvaptan there's an increased risk of hyponatremia in this setting, and that is if people push water 6 liters, that surely doesn't make any sense. But if anybody else in the field says, I'm fine, my patients drink 1.5 liters, 2 liters, which I would advise, because just for the kidney stones and everything else, somebody who drinks 0.5 liter a day, that's probably a problem. But that's totally fine as well, and I can understand the reasons for that, seeing the lack of data. Now, the other things one should definitely go for is lowering salt intake for many reasons. All the reasons we know in chronic kidney disease, we know in blood pressure, we know in cardiovascular outcome, and also because obviously osmolyte intake will then increase vasopressin excretion. So we definitely, for ADPKD, avoid high salt intake. We have post-hoc analysis from the whole PKD trials showing that salt intake at least is associated with faster disease progression. No intervention trial, right? Apart from that, when it gets to diet, it's like, we talk to everybody, a healthy dietary habit would be great. That mainly means avoiding overweight. We know that overweight, obesity is associated with disease progression. That has to be avoided. Apart from that, Mediterranean diet, like everything, extrapolating from cardiovascular disease, or a DASH diet, that's the best data we have nowadays, but no specific data for ADPKD. We have some data that we did in a randomized clinical trial on ketogenic diet, but showing some promising first impact on kidney function, but essentially not enough yet to give a recommendation. That's something leads way beyond what we can discuss today, where we'll talk to our patients and help them as well if they want to change their diet, but there's no general recommendation for this diet yet. We'll need a phase 3-like trial to go there. Apart from that, there's nothing really specific for ADPKD yet, apart from, and then on top of that, on top of the lifestyle patterns, which also include physical exercise, sports, linked to avoiding overweight, there's nothing specific we can do. On the drug side, it's obviously antihypertensives will play a role, and that's for sure. You also asked about tolvaptan, right?
Yeah, how do you advise patients who do start tolvaptan? What do you tell them about water intake and issues?
The first thing I
Blanket
tell them
bottle.
is start on a weekend so you can adapt to that before the first day at work starts.
Yeah.
No, we mainly tell them drink according to thirst, right?
Mhm.
Be aware when you run into settings where you may not be able to do that. Your body tells you exactly when sodium rises, you get so thirsty. As long as you have access to water and you're free to drink, all fine. But if you're on a, I don't know, a long plane flight, or you're traveling through the desert, I don't know, stop that thing. Or surgery, etc. Yeah, so settings, vomiting, diarrhea, in which free water intake or is not guaranteed, or there is massive water loss, lead to the fact that you have to stop the therapy. Now, the apart from that, it's really up to thirst, and it's less it's more about guaranteeing access, and it's less about a specific volume that you need, rather about how can you reduce the volume you need. And the thirst, and this is again linked to osmolyte intake and then mainly salt intake. The more salt you eat, the more osmolytes you eat, you'll need at a setting at which you kind of block urine osmolality to 150 and below, you'll need more water to make up for that, right? And that's when we see patients that have to drink 15 liters per day, and those exist. The majority is 5 to 8 liters, and that's still handleable. You know, you can manage that, but 15 you can't manage anymore. Then there's something wrong with dietary patterns and how they do that. And then we tell them reduce salt intake. Another thing you have to consider is that the nocturia is much more of a problem than going to the toilet per day. So if you have to get up more than 2 to 3 times a night, that's a problem. So if people have problems with that, we again discuss, you might be able to change your dietary patterns from having your largest meal in the evening to lunchtime. And that already changes when you have to excrete your osmolytes.
Yeah,
Maybe
interesting.
not take your tolvaptan too late, but rather start early in the morning and so on. These are kind of the things you can do on an everyday level to avoid this. And the last thing that's currently being examined in a clinical trial as well, where we have some preliminary data and very nice mouse model data, some data from Japan, more data from Groningen, and Groningen is running a large trial now. Hydroprotect is thiazide intake. So like in diabetes insipidus, right, the genetic form, you can reduce urine volume by taking thiazides. And we'd at the moment not use that as a general tool, but we enroll people in that trial, and other people for whom this is not an option, for whom this is the main problem, we at least try that out. And that appears to work, and it's pathophysiologically based on diabetes insipidus, quite understandable it should.
Interesting. That's great. So we're coming to the end right now. So if you had only, one message to give a young and up and coming nephrologist from your vantage point where you're at right now, what would that be? What would you advise our younger colleagues at the moment?
So I definitely advise them that genetic kidney disease is a field for the future. And I have to say that as chair of GNK, but I totally believe so. 30% of the patients in kidney failure have a genetic reason, and this will grow, and we'll be able to target that in a pathophysiologically directed manner. But the key advice I'd give them, look for a field that you're really interested in, invest in a topic you love, you're interested in, rather than picking the low-hanging fruit, go for something you're really motivated for and fight for changing the field in that aspect.
That is so true. That is so true. The passion is important in medicine for sure. Not just for art, for medicine as well.
Yeah, no, absolutely.
Yeah. So the last question is like a getting to know you question. We ask this of all of our guests, and usually they kind of complain this is like the most difficult one. So the question is, which book, 2 songs, and luxury item would you take to a desert island, Roman?
I'll start with a luxury item. I thought about that in the sense I go camping quite a lot, and then you can't take a lot along, right? You always end up with a few luxury items you're missing. And it's actually an unexpected one, but that I like is the salad spinner, that thing with which you spin salad to dry it. Because that's one thing you can't easily replace. You put it into a cloth and run around in circles and so on. So that's a luxury item I'd like to, I don't know, to dry my palm tree leaves before making a saltwater dressing salad. Now, when it gets to the books, to the book, I would say, I thought about this for a moment, but Something that really changed some of my dietary habits was Eating Animals by Jonathan Safran Foer. Now, if you heard about that, but Jonathan Safran Foer did a lot of research on how our meat is produced that if we eat on an everyday basis, and that really reduced my meat intake and will remind me why I'll be so happy on that island that I can eat the ants and crabs running around because those were raised in a different manner, even though it's little meat, but I'll be happy about that. And when it gets to the songs, I don't know that if you're aware that Cologne is one of the key carnival areas worldwide. There is actually much of a tradition about carnival, and there are really funny carnival songs associated with that. Now, I don't come from Cologne and haven't fully gotten acquainted with that tradition yet. Some of them are funny. Others, if you hear them all the time with your kids going to childcare, get in your nerves. And I'm quite convinced I could drive some of the sharks away by using some of the songs. Could be one of those songs. And the second one would be also for good moods, actually, the carnivals. And the second one would be when I have to get rid of the pressure. It has to be a song from the 90s, when I did most of my music experiences in the past. And I'd go for Ugly Kid Joe, Everything About You, which is a song that kind of deals with how much, in that case, the singer hates about a person, and I'd probably rephrase that to the place I'm stuck at.
Yeah.
Get rid of some of the pressure on my mind.
The venting steam song, yeah. Okay. Yeah, I understand that completely. That's a good choice. Roman, thank you very much. This was very enlightening. You explained it extremely well. It was very clear, so really grateful that we did this. And if you have any last words for our listeners, this is the time. Thank you very much.
Thank you very much for having me here today. I'm so glad to see that actually genetic disease, also with Emily's contribution recently, got at the focus of many different teaching formats in ERA, and I'm happy to contribute there. And I think this will be very helpful to many people in the field in the future.
That's true. Thank you. Bye-bye.
Bye-bye.